happy to introduce Professor Ipsika Prabhamani Madam. She is my teacher from Stanley Hospital. I am so happy to introduce her. She is a former superintendent of Stanley Medical College. Now she is working as a professor in Savita University, and she is the past president of OBE Society of South India, and she worked as a joint treasurer of IMS Indian Menopausal Society 2000. Now she is currently working as a joint treasurer for IMS 2024 to 25. She is the past IMS Education Committee chairperson 2016 to 18. She is a research member secretary of Savita University. She has conducted various awareness programs for Tamil Nadu paramedical staff, schools and colleges, and has presented and published many papers in index journals and reviewers of Indian Journal of she is a PhD guide. She is itself a PhD. She has obtained a PhD, and she is a PhD guide for SMC, Savita University. She is trained in robotic surgery.
Thank you. At the outset, I thank God for the wonderful conference, and the topics were so good. And a special word of thanks to Dr. Chakravarti and Dr. Omya. They come here to talk about the risk assessment in peri and postmenopausal women. So when the topic is given to me, a few questions came to my mind. What is the risk assessment? Does it require a special skill? How to categorize for risk of disease? What are all the stages in risk management? What are the strategy to reduce the risk? So the life expectancy globally is increasing. So there is a shift in midlife duration. So previously, now it is between 35 to 40, we call them midlife. And midlife serves as an important preparation for the later part of life. Actually, when you have a good health at midlife, that is the biggest insurance for your later part of health. So, the midlife in women is an ideal time to think and evaluate their health, and it is an ideal time to assess the health risk so that they can enjoy quality of health later on. So, what are all the risks they are prone for? So, their obesity is there, the central abdominal obesity they are more prone for. Because of that, metabolic syndrome, cardiovascular disease, diabetes, cancer, and later on the osteoporosis, psychological impact, and very late they can develop Alzheimer and dementia. So what is the problem? They may have an interpersonal relationship. There is a financial burden on the individual and the social burden also. So it's going to be a big public health problem. So when we look at it, we have to identify and screen them from middle age. So of course the family history is very, very important. History of malignancy, history of diabetes and osteoporosis and fracture. And in reproductive age, PCOS and hypertension during pregnancy, GDM, they are all going to have a risk at midlife. So of course the midlife abdominal obesity, the dyslipidemia, cardiovascular disease and mood disorders are more common, and as they grow old, they are more prone for sarcopenia and osteoporosis. So at midlife, we have to have a proper health. So this is what I was talking to you. In midlife, there is an increased central obesity that causes insulin resistance, and there is a vicious cycle, hypertension, cardiovascular disease, dyslipidemia, coagulatory problems also. So when you look at the statistic, metabolic syndrome is increased from 16 to 64 from peri to menopause age group. It's not moving. Okay. So what happens in peri and postmenopause? Because of the estrogen withdrawal, a lot of problems they can have. Vasomotor instability, sleep disturbance, somatic pain, back pain, stiffness, psychological symptoms, mood swings, urogenital symptoms. And later on, long term, they can have coronary heart disease, osteoporosis, cognitive function, and Alzheimer also. Thereby, it reduces the quality of life. So, the menopause is an identical milestone in a woman, and menopause transition and the time afterwards are important period for risk assessment and its prevention. so that each woman can enjoy maximum health later on. So what is the risk assessment? What we do is they estimate the risk of disease in an apparently healthy asymptomatic individuals based upon assessment of multiple variables. No single risk model is appropriate for all patients. So it doesn't require any skill. So how do we assess? The assessment is a numerical estimate is made of the probability. From the probability we calculate the risk assessment. It can be high when it is certain that it is going to harm, and when it is medium, then the harm may often occur, and when it is low, it seldom occurs. So that is how they classify. So the stages in risk management will be, we have to identify the risk, evaluate the associated risk, control the risk. That is how we have to do. So how do we assess the risk in midlife? There are offline and online assessment tools are there. The basic thing in our clinics, we can do a BMI chart, obesity and weight hip ratio, so that the visceral obesity can be detected. Menopause rating scale is there, so that we know we can classify psychological, somatic, or environmental, urogenital. So cardiovascular risk assessment tool is there. ASTA is a fracture risk assessment. These are all available offline, and sarcopenia can be assessed also offline. There is a it can assess by 5 items. There is a muscle health assessment. Similarly, we have online breast risk assessment. There is a GAIL model, WHO fracture risk assessment called FRAX, and one midlife beyond app, which is freely available in Google Play Store and Android phone. So these are all the tools which we have. So this is a Timples tool which can be kept in our consultation room, so that as per the BMI, see Indian BMI is a little different from WHO. We can tell them the intervention also. Takes time to move. So the waist hip ratio according to the Indians, when it is 72 centimeters, we have to avoid weight and lose weight. And when it is more than 80, we have to have supervised weight management. This is, we can simply do it in a clinic. So similarly, menopause rating scale is there. There is, so based on that, it is classified into somatic, psychological and urogenital. So it is grouped, there are 11 items are there, it is grouped according to the symptom. So each one is a little scale, 0 to 4. It can be no symptom, mild, moderate and severe. When it is less than 11, it is considered they are asymptomatic. When it is between 12 and 35, they have mild or moderate. When it is more than 36, it is severe. Based on that, we can give them a counseling or the treatment. So this another chart is available, which is done by the WHO. It is for the smoker, non-smoker, male, female, and with diabetes, without diabetes. We can easily check and tell them this is your risk, 10% or less than 10%. And all that you have to know her age, the blood pressure and the cholesterol. Cholesterol will be, so based on that we can see if the patient, this patient is age 44, her this thing is, cholesterol is 8 millimole. So based on that, her risk is 20 to 30%. It's a very easily available chart, so that we can assess the risk assessment. So the OSTA is mainly based by the age and the weight. This patient is having a weight of 44, age is 61, so it comes under low risk. See, these are all the small tools which is available. And sarcopenia we can assess with this scale, and it is more than 4 to 6, it confirms they have a sarcopenia, and we have to go for further modalities to confirm it. So this is a FRAS, this is a country specific for osteoporosis. We have to give certain details, age, and we can predict even without BMD. That gives output in percentage, which indicates major osteoporotic risk factor, and the hip, arm, spine fractures. All this can be calculated. This is an online risk assessment. Again, the GAIL model, It is online. You have to feed the age, race, age at first, live birth, age at menarche, so on. Something if you feed, it always gives the risk by low, moderate or high. Lifetime risk assessment. So this is the app which I have developed. It's meant specially for midlife app. Can you play this? Hello? Can you play the video? So all the information, sir, like the menopause rating scale is available in that, and your osteoporosis assessment can be done, sarcopenia assessment can be done, breast risk can be done, and the report will come as a PDO. It is freely available in Google Store, Play Store, but it's available only in Android. So we can do all this risk assessment with your fingertips itself. All that you have to feed, it will categorize whether they have a somatic or psychological or urogenital, whether it's a mild, moderate, severe, everything is given, and finally it gives one PDF also. So it's very useful tool. And why we are the strategy, having find out the risk, we should advise them. If they are having no risk or anything, they are just coming for screening, you should tell them lifestyle modification, calcium, vitamin D supplementation. So if they have a risk, appropriate medical therapy. If they have symptoms of menopause, you have to give them menopause hormone therapy. When you find mild osteoporotic, we teach them fall prevention strategy, so on. So what is the value? It improves overall quality of our care, encourage awareness, enhance physician-patient relationship. It improves our trust, dispels misperception, always unwarranted fears we can remove. It provides basis for discussion also. So women are the pivot of universe. Women are the axle around whom the family, the society, maybe the whole universe is revolving. So our health is utmost important at all stages of life, more so in midlife and beyond. So the risk assessment is very useful, and it is a potential tool to prevent chronic disease, and prevention is the duty of every gynecologist. So by doing risk assessment, we can make them fit at 40, strong at 60, and independence at 80. So women's health is the nation's health. Thank you for patient listening.
Thank you, ma'am, for highlighting midlife and beyond women's life by doing this assessment. As a gynecologist, we often forget to do this. So thank you for making an awareness to all the physicians to do the risk assessment, because the woman's life is with the physicians also. So we can help them to achieve a moderate life and healthy life and beyond. Thank you, ma'am, for your nice presentation.
It's my pleasure to introduce Dr. Uma Ram. She is a director and consultant OBGYN Sitapati Clinic and Hospital, Chennai. She is a chairperson RCOG IRC India South. She is examiner Part 3 MRCOG, contributed chapters, edited books, publications on GDM and multiple pregnancy. And her area of interest is fetal growth, multiple pregnancy, and fetoscopy, GDM, health awareness in women. Her hobbies are music, travel, and reading. Welcome, ma'am.
Thank you very much. At the outset, I'd like to thank all the members of KOGS, congratulate them on a wonderful series of workshops yesterday, and for this meeting. Can I have my slides? So when I got this call to say, can you talk about redefining the OG curriculum, I actually wondered why they had picked on me. I guess the only reason could be that I am involved in teaching and training for the MRCOG, and I do have the insight from having trained a lot of young OBGYNs who finish their post-graduation and then come and work for a couple of years, and so there is a certain insight that comes from that. Okay, so you'll all agree that as OBGYNs, we are a very unique specialty because we take care of two lives. It used to be said 2 generations, but today with the insight that we can actually impact transgenerational transfer of NCD, we can actually possibly impact 3 generations. And with that comes a certain responsibility which possibly no other specialty has. And it is to groom young minds to take up this responsibility that the OBGYN curriculum is focused. Now if you look at word clouds, you can see a lot of words that come around obstetrics and gynecology. And if you look at a word cloud around training in obstetrics and gynecology, there's a lot that is demanded of the young OBGYN, right? The words that have come up are hardworking, dedicated, compassionate, resourceful, outstanding, team player. It's a large set of attributes. And so when we think of a curriculum for obstetrics and gynecology, it's not enough to just think of the subjects that are going to be covered in that curriculum, but also to think about whether we are, building the capacity to handle what they are expected to handle in the future. So if you look, we expect the young OBGYN to be knowledgeable, of course, to be skilled across various types of skills. We want our graduates to be safe for the woman that he or she is caring for. They need to be updated. They need to have an orientation to research, and they have to be committed to the care of the woman who's going to come towards them. That's not all. We also expect them to be able to communicate. We want them to show empathy. We want them to work as a team because increasingly we are aware that you can't function as a solo individual. As an obstetrician gynecologist, you have to be a part of the team, whether you're taking care of somebody in the labor ward, whether you're managing a pregnancy which has medical disease or a fetus with a problem, whether you're dealing with oncology, reproductive medicine. It's always a teamwork. They have to have the skill sets to prioritize what is important, what is urgent, what can be put away till the crisis is managed. At the same time, they must be spot on when managing an emergency, whether that is a maternal collapse, whether that's an injured bladder, whether it is a flat baby. And they also need to know how to handle such adverse events and to debrief the woman, the family and their team. So all of that is what the OBGYN curriculum has to inculcate into that young mind. Now additionally, they also want to know about practice management, medico-legal implications, and these are all things that the current generation needs to know. They need to know how to manage their practice. They need to know how to handle a medico-legal problem. They need to know how to handle violence, right? Because it's a huge problem today. And they also need to know how to balance family. Because unlike 20 years ago, the students of today do want to have a work-life balance. So if you tell them you just have to do 24 hours on labor ward straight, they are not particularly happy about doing it. They also need to have a financial sense of how to go about setting up their practice, and most importantly, at the end of all of that, they must have a good sense of well-being, including emotional and mental well-being. So any OG curriculum today needs to address all these issues as well as teaching them the fundamentals of the theory of obstetrics and gynecology. As if that's not demanding enough, today's patient is definitely better informed. Unlike my father who used to just write a prescription, turn it around and say, this is what you have to take, come back and see me after 2 weeks, the person will just quietly take and go away. If he says, you don't need surgery now, no questions asked, right? But we are not in that situation right now. Our patients are better informed, they have often consulted elsewhere, and they won't tell you that until you finish your entire counseling, and then they will ask you, but why did so and so say that? Sometimes they are sussing you up to see whether you have actually told them everything that the other person has spoken to them about. They have internet sites which give them information and ask them what they should ask their doctor. They come for a discussion rather than advice, and they seek your time. They seek that you respect them, and they want your empathy. So there is a very, very demanding patient to whom we are now providing care. So the points to ponder when we think about curriculum is the content. And this content actually is very elaborate. And I actually picked some knowledge of Dr. Hepzibah and a few others who are very trained teachers. If you look at the curriculum on any of the sites, whether it is Tamil Nadu MGR University or DNB or JIPMER, the curriculum is laid out beautifully. There is nothing there that is not already listed. So everything is in place. The question is it delivered, and is it, is the postgraduate student receiving it in the way in which it was meant to be executed? So the problem is not that the curriculum needs to change, is it executed appropriately? And there are challenges to execution based upon the setup in which this training is happened. If you are in an extremely busy medical college public hospital, the person who is teaching may not have the time to teach simply because he or she is handling so much volume. In more younger private teaching hospitals, you may have a very interested teacher, but you may not have the patient load on which you can execute the teaching. So the challenges are different in different setups. What about the duration of training, right? In India, most of the time it's 3 years. If you think about the US, it's 4 years. If you look at the membership training for the RCOG, it is 7 years. The MRCOG is not an exit exam. It is an exam which gives you a degree halfway through your training, and you still have to do another 3 to 4 years, or at least 2 to 3 years, depending on when you get your membership, to be able to say I am practicing as a consultant. Whereas at the end of 3 years of training here, most of us are let loose on the world and told you are independent with the ability to practice. Which is why a lot of them go here and there for training to gather additional strength. Very important that, and this is increasingly being incorporated into our curriculum, is non-technical skills, whether it is communication. Communication not just with the patient but with your teammates. How do you communicate the clinical situation? And is there situational awareness? Do you know what is happening? Do you have like a helicopter view of the whole situation? Can you as a leader take charge of what is happening in the labor ward? Can you prioritize? So these are all non-technical skills that get integrated into the curriculum and needs to be integrated into some of our curriculum as well. Resilience building is very important, and this is not just an issue of OBGYNs. I think it's an issue because of the way education is till they reach the postgraduate training. Everything is exam based and exam success, and a lot of time our parenting styles also are to tell them you can just sit and study, crack the exam, we will handle everything else around you. And suddenly they are left to face a world where nobody is going to clean up their mess. They have to actually deal with everything themselves. So that again is an issue, and resilience building becomes extremely important, and that probably needs to start before they get into medicine or definitely into post-graduation, and then to have a very supportive peer group, which I think increasingly this generation is also realizing, because they are not against one another, and we all have to work together and be supportive of one another. So what can be done better in our current curriculum, given that everything is already written out as it should be? Probably periodic assessments and competency sign-offs are coming in as part of the curriculum, but is it done well? Is it implemented appropriately? What happens if you have a trainee who's having trouble? Can you hold that person back? Do we have the time to scale up their skill so that they can move forward? So is there a process to help a trainee who's not as good as somebody who can learn competencies? We all know some of us may be very good surgically, some do not have the hand or the eye for surgery, but they may be good somewhere else. But yet, a basic competence in everything is required. Communication, again, I think has to be focused. People have to be taught what to say, how to handle a situation. When we speak to postgraduates, they often say they are troubled by discrepancy in management. What they read in the book is one thing, what their own teachers may tell them when they take class is one thing, but what they actually see in patient management is something else. And so if you have never seen somebody with meconium being allowed to deliver normally, if you have, then you are not going to be able to have the confidence to do it when you are all alone and you are managing a patient in labor. So that's important. Orientation before they start off. This is something that a lot of postgraduates have said, that they suddenly feel like they're left in the deep end without an orientation of this is what is expected of you at different points in time. Research methodology, discussion around dissertation. This gets done with varying levels of ability depending on the institution and depending on the trainer. But there isn't a universal understanding of basic research methodology which is beneficial for everybody to have. I think most postgraduates are very happy with obstetric loads, but they don't have the confidence on managing gynae. If you see somebody with AUB in the private practice and they are seated with you, they are actually quite at a loss as to what to prescribe, how to do, when to come back. Laparoscopy skills is something they all go out and learn. Even though there are ways in which basic skills can be learned, almost all the postgraduates spend a varying degree of 3 to 6 to 1 year depending on their interest learning laparoscopy skills elsewhere. Fertility management is something that maybe needs to be added a bit more, but again, if you are in a large public hospital, fertility management is not your priority, and we just heard Dr. Chakravarti say that there isn't ART in public hospitals. Hopefully the need will be filled. Ultrasound is a very fundamental OBGYN skill. You cannot practice if you don't know how to do a basic, well-done ultrasound. And by that I mean a gynae assessment and early pregnancy scan. We are not talking about fetal medicine. So understanding that probe orientation, what to do, how to do, a lot of them don't have that skill, even though they may have had 2 or 3 weeks posting in radiology in the hospital. They don't actually learn the skills. Exposure to other allied departments. And the biggest difference I think we can make is to make postgraduates understand that yes, there is all these options, but what can we do for this woman in this situation? And also emphasis on ethical practice, where we have to teach by example. As I said before, handling medical legal issues, and a lot of them feel a little bereft at the end of their course because they want guidance on what options they have after they finish. Where can they go? What are their options for work? Some of them obviously have good guidance, but some of them don't. Now, bullying, burnout and mental health are issues that we hear about everywhere. I haven't directly experienced this in OBS and gynae, but I know of classmates of my son who are doing their post-graduation in anesthesia and surgery elsewhere, and who are experiencing significant bullying. Couple of them have had significant mental health issues, including an attempt at suicide. And I think when you are picking postgraduates who have put in so much of effort and so many exams to get where they have got, and being doctors ourselves, there is absolutely no excuse to let somebody go down on the mental health route. It is really heartbreaking. If you hear from some colleges where the people say that 3 of my 5 colleagues are taking help for depression. So we say that the PG should have all these values: kindness, compassion, empathy, dignity, the ability to listen. I think the system owes them that we are able to offer the same thing to them. So this is all data on bullying from the West. I don't know if we have data on our own people. But the interesting the data there is though less number of women are bullies, if it's a woman bully, she tends to bully other women more. And I think that's something that we should, a little bit of a mother-in-law syndrome perhaps, but we need to watch ourselves as trainers. So we know all these things about a good learner, but I think we also need to understand that our selection processes actually doesn't assess aptitude, it just assesses exam taking skills. But I want to spend the last couple of minutes to talk about a teacher. In the words of Gibran, a good teacher, if he is indeed wise, does not bid you to enter the house of his wisdom, but rather leads you to the threshold of your own mind. So I think the trouble is that if you take the different types of discussions that are possible, the retention from lectures is only 50%. But not everybody who's a trainer or an assistant professor actually has undergone significant training to be a teacher. And we are expecting somebody to be a teacher, to have the knowledge, to understand what are the different tools available to them, to be able to organize, to deliver information in a level appropriate manner. Is it a first year, third year, what is happening? To also be able to assess. Assessing somebody itself is a skill, and not all of us have that appropriately, and time management. So I think people who are teaching also have to go through some kind of evaluation, guidance, support so that they can teach. And we have many plug and play models. Everything does not have to be reinvented. There are basic surgical skills, basic gynae skills. Issue of does a basic ultrasound training course. There are so many skilled laparoscopic surgeons who can offer a basic lap skill training. So these can be plugged and played. So to redefining the curriculum, I think the curriculum is already in place. It's the implementation that we have to focus on, ensure that skill development is appropriate for current practice, be ethical and evidence-based, prepare them for the real world, keeping their mental wellness also in mind. Thank you very much.
It was indeed a very interesting and enlightening lecture, and I think the execution of the present curriculum is a need of an hour.
Next, we invite Dr. Sampath Kumari ma'am to give a keynote on adolescence, key for the future. Welcome to the stage.
Good afternoon, ma'am. It's an honor to welcome Professor Sampath Kumari madam. She is at present a professor of Muthukumaran Medical College and Research Institution. She is a Foxy Vice President of 2022 and 23. She is the founder secretary of TN Walk, and she is the national correspondent for editor Jogi 2021 to 24. She is a Senate member of Tamil Nadu India University 2021 to 24. She is a chairperson for Foxy Adolescent Health Committee 2016 to 18. And she is the president for Board of Studies OG Tamil Nadu Medical University. Welcome, ma'am, for the talk.
First of all, I thank the Conference Society President of the Secretary, and Kirtika, the Treasurer, for giving me an opportunity to address the gathering in the subject which I like, adolescence. See, my agenda will be like introduction, stages of growth, and the problems with the adolescents, and how we are going to tackle, and finally the take-home message. See, why we are. See, now today, 1 of every 5 Indian is an adolescent. There are 253 million adolescents in the age group of 10 to 19 years. Today, the Indian population, here this is the population as on date of 2023. Now, again, the adolescent population has increased. This is the President of World Bank Group. He has told that today's youth are tomorrow's workers, entrepreneurs, parents, active citizens, indeed leaders. And because of failing fertility, they will have fewer children than their parents, as they move through the adulthood. This in turn may boost the growth. How? By raising the share of the population that is working and by boosting the household savings. Rich and poor countries alike need to seize this opportunity before the aging of the society closes it. So doing so will enable them to grow faster and reduce poverty even further. So India, it is a vibrant state. In India only the adolescent population in the world, India has the largest adolescent population. As per statistics again, 253.2 million are there, constituting about 23%. The introduction. Why we want to talk about the adolescents? They are neither children nor an adult. It is a transition from childhood to adulthood. So adolescents can also be called as the puberty. Why we are talking? As per WHO, 10 to 19 years or adolescent. It is the unique stage of human development and important time for laying the foundations of good health. Why we want to talk about the adolescence? As I told, it is a critical link between the childhood and the adulthood. Physically, physiologically, endocrinologically and social transitions. During this period, they themselves don't know what to do sometimes. Whether what they are doing is correct, whom to approach, how to approach. These are all the questions which goes behind the mind of the adolescents. The transitions carry new risks but also present opportunity to positively influence the immediate and future health of the young people. See, how does our adolescence affect one life? See, they have stronger reasoning skills and logical and moral thinking. See, we think that these are the adolescents, whatever they decide, it is not good. But they have the mind of thinking is logical and it is very moral. And abstract thinking. See, even for all of the Tamil Nadu people will be knowing about the Jallikattu. Even the politicians cannot do. Only the youth, the adolescents, they did. So this is the way that the adolescents, they are strong in what they want to do it. The changes in the adolescents environment both affect and are affected by the internal changes. See, we are telling the adolescents are making mistakes. We teach about good touch, bad touch, that and all. This is not the mistake of the adolescents. It is because of the hormonal effect. So we have to train them what is to be done, how is to be done. So this is the statistics I think all of us will be knowing. 45% of the girls are undernourished and 25% of the adolescent boys and 20-30% are sexually active. Whenever we were adolescents, if in the TV something which I have if it is coming means, the next minute they will tell, go and bring coffee, go and bring water, because the next point is it is the first night. Nowadays it is not like that. For the first night, 1 year serial is going on. So what we can do? Nothing can be done. So this is the condoms. About the contraception, 60% of the adolescents, boys and girls, they are no aware of this contraception. So we have to talk to them. The mother should talk to the girl, put her leading questions and ask whatever the doubt she has, she has to clear it. And why it is difficult? Because of the rapid physical development and the deep emotional changes. The adolescents themselves are excited. For example, the girls during the menstruation, they are excited, they do not know what is happening, whether it is good or bad. Similarly, boys, we always talk about only by the adolescent girls. The boys, they do not know what is masturbation. Sometimes they think that itself a disease. If the parents, they are going to clear his doubts, he will be happy. So this is a normal phenomenon, but it is not an abnormal and it is not a disease. So they are confused and they are uncomfortable whom to ask. So similarly in the schools, the teachers should talk to them about the reproductive cycles, how the menstruation happens, how the ovulation happens, everything has to be explained. I used to do the school counseling and all. You will not believe, one corporate school, 7th standard girl, she asked me, if a boyfriend kisses me, can I become pregnant? And she asked how many times in a month we can use the easy pills. So these are all the doubts of adolescents. So facts about adolescent development. It is a time, remarkable opportunity. Always we used to tell sweet 16, 16 vayadile. Then adolescents are drawn to the novel experiences. They don't know what to do. They want to do something different. So whether what they are doing is it correct or not, they don't know. If the peer friends, they are taking the alcohol, they want to taste what is alcohol. So once if we tell them, if you are going to become an addict to the alcohol, you may have an hepatic carcinoma. So it is our duty, it is the duty of the parents, teachers, social and everyone. Then the adolescents earlier, then see we will be thinking whether this thing can be done or not. During the time we think the adolescents would have done that work. So that is that we think and that work will be also good. Similarly, adolescents brain are adapting to the developmental task of the stage life. For example, medicine. We used to write long questions, 10 mark questions, 5 mark questions. Finally, what it came, the NEET exam. Now, for MBBS students, there is no theory questions at all. Only MCQ. They are going to adapt. If I was doing an MBBS and only MCQ, I don't know whether I would have passed or not. Because MCQ is very, very difficult. As we think it is not an easy. So these adolescents are adopting. MCQ, okay, no need for theory class. Teach us how we can be fit with the MCQ questions. This is the way they are asking. The adolescents are highly sensitive to respect. See, we cannot tell that I have never talked to my father. If I want to get anything from my father, it is through mother. Nowadays it is not like that. Whatever they want, they will get. Whether through mother or father or somewhere they will get. And they need the respect. So I used to tell, you give only the information, don't give advice to the adolescents. If you give advice, they will never do the work. They will repeatedly make mistakes. Night, everything in the same room. The adolescent, he may not be, he will see something which should not be seen. So he will try to experiment that. This is the problem. And the family background. We were sitting with grandfather and grandmother. If mother and father going to job, grandfather and grandmother will take care. Now the adolescents, even if they come by 12 o'clock, they have a single key at what time they are going to bed, at what food they are taking. Even the parents may not be knowing. So in that situations, what they will do, they will decide whatever they want. Then the social class, knowledge and availability of contraceptives. Social factors, again, mass media, religious teaching. This mass, now the media has become height, weight, bone mass, everything increases only during the adolescence and the development of the secondary sexual characters, the physical changes. As I told, the development of the breast, it itself will be exciting for a girl. Then the parents should help. What is that? How the bleeding occurs? It is normal. When it is normal, when it is abnormal, everything has to be explained. So this is which way I told that masturbation. One of the boy was asking. I used to do the counseling not only for girls, even for the boys. The boy was asking because they will not ask in the public. Once the class is finished, I will sit there and they will write in a paper and give the sheet and we will answer that questions. We can have different questions which we may not, we ourselves may not be able to answer it. So these are all the situations, the physical changes, the adolescent years. Next comes this neurons. See, at the beginning of the puberty, neurons are gaining and losing up to 25% of the connections each week. And by the time they reach adulthood, it drops to 10%. The rapidly changing adolescent brain is especially sensitive to the social environment during this period of development. So this is the reason they won't have the experimental learning. That Umaram was talking about most of the topics. I think Dr. Umaram have already told that period of building resiliences and ever having the earlier hardships. So the adolescent's brain are neither immature nor incomplete. Similarly, with the hormonal effect, nowadays it has become, see, the girl will tell, I have 2 boyfriends. How many friends you have? They will tell that the boy is coming behind me when I go out. But if the boy is not coming behind her, she will be upset. See, this boy is going behind with my friend, but he is not coming behind me. So these are all the situations, the body shape, everything. They will see in the mirror.
See, can you see any boy or any girl when they go out without seeing the mirror? They will definitely see the mirror. Everyone wants to look good. For that we cannot tell. So during adolescence, the brain becomes more responsive to dopamine and the hormones. These are all the normal physiological which we cannot scold the adolescents. To harness this drive in positive directions, adolescents need safe and satisfying opportunities for positive exploration. We always tell this girls are making mistakes, boys are making mistakes. Where they learn the mistakes? The parents leave the children to the nearby house that they may think that he is 50 years and 60 years, he will treat the child or the boy with care. But it is not like that. He is the culprit. From him only the girl knows everything, what she can do. If he wanted to do the things which the girl doesn't know that is wrong, that girl will understand that this is the normal. So this has to be continued everywhere. So always the parents, this point I learned from Dr. Chakravarti sir only. He used to tell, morning wherever you go, afternoon wherever you go, night dinner, mother, father, children, all of you sit together and take the dinner. Then you will have the opportunity to know about your partner and know about your children. Put the leading questions. Where did you go? Girlfriend or boyfriend? What did you do? Whether school books or other books, whatever it is. So night, all of you sit together and spend at least 30 minutes with your children. The positive factors to be borne in mind is adolescents still seek. See, always we tell that the girls will not, girls or boys, they will not listen to the parents. See, even for making mistake, they need the support of the parents. I think most of you would have been aware of that RV movie. In that the girl became HIV positive. The father was very angry and the girl was sent out. The last minute in the death, she sent a video telling that she wanted to talk to her father. So even for mistakes, since we are not listening to them, this is the problem, they don't know where to consult. So everything, whether good or bad, they want to get the support from the parents. Even the schools, the girl is getting 20%, 30% and she will approach the teacher. Because whom she can approach? She can approach only the teacher. The teacher has to take extra effort to make the 30% to 60%. But none is doing. They will take some, there are some schools, they will have only all students above 95%. What is the point in educating a student who is already brilliant? Who is not brilliant only has to be educated. So it is important to discuss the puberty and the sexual development. Similarly, what is good touch, what is bad touch, this we have to tell. And the way this is good touch, this is bad touch, we cannot tell. Which is the sensitive part, what will happen? Once immediately, as they see in the movie, taking the, with a cup of juice, they cannot become pregnant. Repeatedly, that is the reason they will go for a pregnancy. The most important is establishing relationship and social life, and unlike children, they kind of have to do their own. The area of focus, rapid social learning, increasing the sensitivity to respect, these are all the new experiences. And the typical teen behavior, when we can tell that she is a teenage. When the girl is always angry with her mother, then she is the teenage girl. She cannot show the anger to anyone, only to the mother. So these are all the important feel awkward and switch between the overconfident, follow friends example, find fault with the parents. That we cannot tell that he is trolling like that. You should talk to him, sit with the girl or a boy and ask what is your problem, who is your boyfriend, one or two, what happened to him, whether he is continuing or whether there is a breakup. So you should talk openly. If you talk only, the adolescents will go for a good in future. So I think these are all the rise of concern. And the kada avadi saathiru poranga, some problem is there. So we have to ask them, what happened? Why are you breaking the door? So these are, next comes the adolescent suicide. They don't have the tolerance. See, 2 minutes, if they want some, any depressions, always we give whatever they want, laptop, dress, whatever it is. Can we give the alcohol and smoking? They cannot get from the parents. So if they don't get, they will get depressed. Drug abuse, similarly. So talk to them. If they want to go for the suicidal, it is only 2 minutes. I usually, when I go for a school counseling, I used to tell, Everyone cannot get 100%. Somebody should get 30%. So when you feel depressed, don't decide anything. In the depression and anger, don't decide anything. Close your eye and count from 1 to 100. Postpone your suicidal tendency. Now the suicidal tendency with adolescents has increased. So we have to talk to them. They should come out of the depression and they should come out of the anger. Next comes this National Crime Record, that is NCRB. In 2022, what does it tell? A student took their own life every 42 minutes. That is more than 31 students died by the suicide. Now we are telling that the suicidal incidents, it is more with the boys compared to the girls. We think only girls are committing suicide. Even the boys, that has to be counseled. Next, this is education in India. Education, we think that we want to do the undergraduation, post-graduations, then PhD, whatever it is. Why we are doing the education? Education is not to get the job. Education is for culture. So I have done everything, I am not getting the job, so I will commit suicide. It is not like that. So you should tell them, education is for your culture. There is a difference between who is educated and not educated. That is the reason we ask, Padichavan ipdi pannalama. So education is to create the culture. This is not only for the job purposes. Next comes this adolescent crimes in India. How the adolescents are making crime. For this also I can quote one movie, I think with Vijay Sethupathi and Vijay was acting. See, all mistakes is done by the villain, Vijay Sethupathi. But what happens? Somebody who is less than 18 years, he was made to take the mistake. Because 18 years means there is no punishment. This is the way this incidence of adolescents crime is going. If you are going to tune them in that way, how the adolescents will go for a good future. I forgot that movie name. So according to 2021 annual crime data, there was an increase of at least 7.6 in crimes committed by minors. That is the juvenile offenders. 2,455 crimes in 2020 against 2,643 crimes in 2021. These adolescents are not doing the crime. The mistake was what they are made to do this crime, to make somebody free from the punishment. So the causes of youth crime, again it is from the social, parental involvement, depression, low family income. Normally the girls 16 years means everyone likes to have a good dress and good perfumes. If they don't have the money, there will be the depression, and that is the incidences they may try to go for a small crime like stealing. So we should counsel. There is a time, you reap, you yearn, the situation will come. In that time you can have a good dresses, good perfumes, whatever it is. The risk factors from the others, influentials, uninvolvement, unemployment, exposure to violence in the family. This is from the environmental, which make the adolescent to make crime. These are all the major problems. The other problems that need a closer look is anemia. This all of us know. A girl is 12 years, she should have been 12 grams of hemoglobin. If you don't correct it, it will end in MMR, which is due to anemia. The nutrition. Next comes the sexual abuse, which I told. Most of the sexual abuse is only by the known person, because the girls, they don't come and report. See, what do you know can hurt me. So we should know if there is sexual abuse, what will be her psychological condition, what will be her reproductive problems, there will be an injury. So we have to talk, psychologically she will be affected. It is only an accidental. You cannot continuously go and blame on the girl. So we have to talk to her and we should make her free from that situation. Whenever she goes for the sleep, she will think of the sexual abuse. So we have to talk to her. This is the child sexual numbers, everything, that POCSO Act. We know that it is not only the rape. If somebody talks against somebody, criticize the boy, criticize the girl, again the punishment with the POCSO Act. So every girl and a boy should be aware of the POCSO Act These are all the other problems with the teenage pregnancy, 15 to 19 years, what complications can happen, teen abortions. When we were, that is during the house agency, if an unmarried girl comes to the OP, she will get scolding from the person who is making the ticket to the OP sheet up to the, we can have even the chief, sorry sir. But nowadays it is not like that. Marriage is not at all an indication for pregnancy or for abortion, for everything. Nowadays it is respectful abortion care. It is not, she may not have done it voluntarily. It may be accidental. So if a girl with 18 years comes with pregnancy and if she wants abortion means, you do it. But as per POCSO Act, first report to the police and then you give the treatment. So we should be also safe. So always respectful abortion care. It is her intention. If she wants to continue means let her continue. Then we should talk to them about the contraception to reduce the incidence of HIV. And always this is a good, I like this slide. Wherever I go this slide, I always like to use to talk. Take pleasure and pride in saying no. Whenever you want to say no, if a boy is following, tell no, don't follow me. To send in a polite manner, I want to become so and so, I have a lot of commitments. If you want to get married, come and talk to my parents, I will wait. This is the way, so you should be proud to say no. This I think similarly boys, no means no, whether it is your girlfriend or a wife or sex worker. So this word no has lot of importance for girl and the boy. Then the exercises, 3 meals, 3 snacks, 30 minutes exercise. This you have to tell, if you go and ask a +2 student to do exercise, how she will do. So ask her to do sit-ups for 30 minutes. That's all. The media, as I told, technology is a double-edged sword. Positive use results in betterment. Corona, classes, pass. Negative use, ruin the basement. We are seeing bullying and everything. There are many things are there, networking, instant messaging. Boyfriend, they would not have seen the face also, but continuously chatting. Finally, there may not be a boy like that. It will be only a message. For that, you cannot go for a depression. Then the parents, seize the moment, be direct, consider the teen's point of view, always talk with the anatomical parts. The school, again give the health counseling. Yes, I am finishing. So adolescents are like glass. If you handle them, it will be very safe. If you don't handle them, it will be broken into pieces. For the girls, they will not tell. So if they come to the OP, ask them, is there anyone touched you in a way which you don't want it? Have anyone asked you to touch in a way which you don't want it? These are the similar leading questions you can talk to the adolescents. So finally, this is the 10 core life skills of the adolescents. Self-awareness, empathy, critical thinking, creative thinking, decision making, problem solving, effective communication. The adolescent should get confidence with one. It can be a mother, or it can be a father, it can be a teacher, or it can be even a health worker. Interpersonal relationship, coping with the stress, coping with the emotion. These 10 points are important for the life skills. So the summary is, adolescence is a period of turmoil. Spend adequate time. Approach them with respect and friendly. Understand their problems. Do not advise. Share info and incidents. Encourage and support them. Do not hesitate to take professional help. Don't compare. Even the sister and the brother, don't compare. That is very, very important. Let the bud blossom into a vibrant flower. Conclusion, clear myths and misconceptions, promote safety issues for preventing pregnancy and STI, make health services available, deal with consequences of unsafe sex, provide information, sexuality education, empower adolescents. Thank you. Once again, I welcome you all for my VP Foxy conference at Kodaikanal on August 11, 12, 13 at Kodaikanal, Kodai International Hotel. I welcome all of you for this. You can enjoy the academic and the environment. Thank you.
Thank you very much for your extensive talk. Especially everyone, women should practice social obstetrics and social gynecology. It's a responsibility to protect the adolescents, especially the future generations of our nations, to build a strong nation. Thank you, ma'am, for excellent talk.